And we'll go through, the first part of the talk will be kind of a little bit of the boring stuff, the pathoanatomy, things like that, but I promise I'll make it clinically relevant and kind of hopefully open up ideas for treatment and kind of see where the tendinopathy and tendon world is going in terms of how to treat this really pesky problem, although not life-threatening. It's annoying for a lot of our sports patients. Disclosures are online. I would only say just consultant for a couple of products that are not mentioned here, but have to do with the treatment of tendinopathy from Arthrex as well as from Sparta Biomedical. Okay, so tendinopathy is a real pain in the butt. I know some people in this room in particular have had it, and it's really, it's not life-altering, right? But it just causes hoity-toity sports patients to come in and complain to us, and it's non-surgical, so it annoys us a little bit, and we wish we had better answers for it. But the data is pretty clear. About a third of patients who come in with this and stop sports and stop athletic activity are really not able to get back to their pre-pathology levels. So it can be pesky. The incidence is really high. I should probably publish this, but this is from a couple of years ago. And basically, the shoulder is the worst offender for rotator cuff tendinopathy, but obviously everything else in the body with the tendon can cause problems. And if you look at some of the data, upwards of 30 to 40% of people overall in the billing databases have tendinopathy type ICD-9 codes. What's the most? Well, I mentioned, it depends on your age, right? So if you're young and you're playing a lot of sports, it's patellar tendinopathy, which is in that upper left corner, but then as it goes on, the shoulder, hip, and everything else kind of come into play. So it just depends on where you are in your lifespan and how active you're being, but certainly it affects all parts of the body. Risk factors, repetitive jobs, of course. We don't see a lot of factory workers here, but coming from non-peninsula places, we do. Sports participation, right? I mean, we're not going to tell people to not play sports. Certainly has great other effects, but the kind of the dynamic things where but the dynamic sports are good for your health, but maybe not so good for your tendons over many years and decades. But certainly have other benefits. So we're not going to tell you to stop doing them. From a this one's on, Jana. From a metabolic standpoint, there's definitely things that we know that affect tendons. So hypercholesteremia has come in through kind of larger studies over the past number of years that shows it's definitely a primary risk factor for tendinopathy. Of course, not everyone with hypercholesteremia gets tendinopathy. The extremes are the familiar hypercholesteremia situations we all learned about in medical school. I've had a handful of patients over the years with that condition and kind of rip-roaring tendinopathy at multiple locations. Some people in the tendon world advocate screening for hypercholesterol states when you see a patient for tendinopathy. I don't do it, but it's certainly out there in the literature. Fluoroquinolones, we know from the younger population, we don't really like our pediatric patients or young athletes to get fluoroquinolones, and certainly I wouldn't prescribe them, but we do see some tendinopathy and occasional tendon ruptures that are associated, maybe not causal, but associated with fluoroquinolone use. Hypertension, metabolic disease, things like this are all out there in the literature as associations. We can't make causal associations, but certainly a sick person is more likely to have tendinopathy, and those with inflammatory arthropathies we see all the time. We'll talk about it later in the talk. Have rip-roaring kind of tendon disorders and enthesis, where the tendon meets the bone. They have enthesial disorders from their inflammatory arthropathies. And then, of course, sick people get problems, right? So obesity, alcohol use, smoking, things like that. Even contraceptives are out there in the literature. So a whole host of medical things to think about when you're seeing patients with tendinopathy. Other things, obviously, I mentioned if you are using your tendons and stretching them out and putting forces on them, that is going to cause problems. Tendons are made to be durable, right? But at some point, everything fails if you put enough stress on it. So patellar tendon, tendinopathy has shown a number of biomechanical things. So if you land with decreased dorsiflexion of your ankle, If you have decreased flexibility, these are all things that are kind of associated. Again, we can't make cause and effect, but associated with things. And then Achilles, for our long distance runners, is kind of the classic Achilles tendinopathy type of picture. And even pickleball now, we see a lot of Achilles stuff coming up from pickleball. So be careful, Dr. Maloney. But there's a couple of things. So anyway, biomechanical factors are involved, metabolic factors. So just kind of think of it as a broad category of, it's really treating the whole person when you see a tendinopathy issue. It's not just simply, hey, you're running too much. I mean, certainly that's a component, but there can be other things involved that cause the problem. So just a little bit of the boring stuff. So tendons are highly structured, right? And the lack and the breakdown of that structure is what causes tendinopathy. And I'll argue here in a sec. That's really an inflammation-based problem. And that's come up just with our increased kind of diagnostic tools over the past 10 to 20 years. We've really shifted from kind of a pure mechanical problem of the tendon to, yes, there's mechanical overload, but then that mechanical overload is going to kind of start this whole inflammatory process that causes breakdown and problems in the tendon. Mostly collagen, mostly type 1 collagen, and a nice regular organization. If we look at it under H&E slides, if we look at tendinopathy samples under H&E slides, it kind of gets wavy and it doesn't have that nice straight linear patterns anymore. And that's when things break down. So the structural changes, I'm not going to go into a ton, but you get that failure of that nice regular pattern. These fibrils and fascicles break down, and just like lanes on a freeway, they start kind of they'll start curving abnormally, and their collagen components will become different. So what is the issue with the collagen? So I think it was pretty well agreed that the tendon literature, it's mechanical overload, right? So that's always been there. We've always known that. And that type 1 collagen is critical for that strength. The type 1 collagen is that really robust stuff, right? That's the strongest type of collagen you have in your body. Bone is mostly made up of type 1 collagen, so is tendon. So if it occasionally comes up on the basic science portions of the test, what is bone or what is collagen, and you just think of it as type 1 as being the strongest stuff. When we're looking from a biomechanical perspective, which again is the kind of the inciting insult for tendinopathy, you can think of it as kind of it's a little bit of a race between, is there too much overload, or is there enough overload where the body has enough, or is there too little overload where the body has time to recover from it? So think about going out for a run, right? If you're going for a run just for half a mile or so, and most young, healthy, active 20, 30-year-olds or so, you're putting some stress on the Achilles, for instance, maybe the patella a little bit, but mostly on the Achilles. But it's kind of a low level stress, and your body's like, okay, I can handle this. There is collagen turnover, and that collagen turnover happens at a very low level though. So if it's low enough and the load is low enough, your body can handle it and it can deal with the damage that occurs, however little there is in that kind of half-mile run. But if you go out for training for a marathon and you're running 26 miles and your Achilles is saying, what the heck is going on here? I can't handle this, right? And so that low level of normal collagen turnover is just not enough to keep up, and it causes damage in the tendon. So there is some healing of tendon that can occur at low levels of insults, but if you go out and do too much, and that's obviously patient specific, that's what causes the problems. So here's what I'm talking about on the organization. These are slides from my work just a number of years ago, but it's basic stuff that's on the internet too, of course. So top right, normal, regular, linear kind of formula for the tendon. And then bottom right, you can see it's all wavy. And not only is it all wavy, but you see those dark little dots for all the orthopedic surgeons in here. Of course, those dark little dots are cells. So there's increased cellular infiltrate in these tendinopathy tendons. And that, of course, speaks to kind of the inflammatory component that I'm going to talk about in a little bit. When 10, 15 years ago, when I was going through residency, this term angiofibroblastic hyperplasia was kind of the test answer. From the tendon test writers, we're trying to get that out of the lore. Certainly that is a good description from an H&E staining perspective. But when we look at it with immunofluorescence, when we look at it with other kind of PCR, which is not visual modality, of course, but when we look at it from an inflammatory perspective, it's more than just angiofibroblastic, scar tissue with hyperplasia of the tissues and inflammatory and cellular infiltrate and blood vessel infiltrate. It's an inflammatory process. So The term still holds true. And sometimes if you have a test writer, they may put that in there, but we've really moved past this term in terms of what's going on with the tendon, and just because of all the inflammatory molecular tools we have. So what causes it? I mentioned mechanical overload certainly is the start of it. There's no question about that. The new thing, as I mentioned, is what continues it and what causes the problem and continues to cause symptoms over the years. So there's a whole host of things. We're not going to get into all of it just because A, I'm not an expert in all of it, but B, it's long and winded, and there's a lot of Dr. Lane Smith publications on this stuff, which I haven't read in a while, and it's too complicated for me anyway. But mechanical overload's the thing. But then there's other things that go on, and inflammation-based problems is really the final common pathway of all of these things. So everything you see here leads to inflammation and inflammatory infiltrating of the tendon, which is going to cause breakdown of the kind of mechanical structures in the tendon, and that's again what we're going to talk about. This was a colleague of mine's paper from now 2010, really one of, not the seminal, but one of the more seminal papers in the tendinopathy world that basically kind of said, guys, this is an AGSM paper, and kind of said, hey, look, this is happening, this is going on, we need to really change our paradigm about how we look at it. So there's just, H&E stains with looking at macrophages present in the tendinopathy samples. So the dark staining there is, macrophages. You can just see the presence of them and the inflammatory infiltrates in these samples. There's just some work. This is synovium based. This is synovium samples from some of my patients that we looked at a couple years ago, looking at how inflamed not only the tendon is, but also the synovium in shoulder rotator cuff pathology. So the top is normal control patients, young patients who are getting Bankart repairs, and the bottom is older patients getting rotator cuff repairs. And so I just took samples of the synovium. We can see just the inflammatory infiltrate differences between the top and the bottom. So again, it's not only in the tendon, right? There's a whole kind of host. If you're talking about the joint or the shoulder or the tendons in the shoulder, it's the problem happens outside of the tendon also. So inflammation, we talked about it. It's the final common pathway. It's what really causes the problem. But there is an interplay. And this is just a nice diagram, again, from my colleague over in Europe, looking at where this happens. And so just think of it as kind of there's different compartments here. We'll talk about some of the small points here in a sec, but the inflammatory cells have to come from somewhere, right? So you can see them at the top. They're extravasating out of the blood vessel. So there's signaling happening that brings them out of the vessels into the site of damage. So that damage caused by initially mechanical overload and mechanical stretching of the tendon. These resident macrophages, they get pissed off. They start eating away things they're not supposed to be eating away. They bring in other inflammatory cells, and there's this whole host of process where not only are these local inflammatory cells, macrophages, et cetera, causing damage to the actual collagen structure, but they're also bringing in more cells that do further damage. And this is that whole process that leads to the kind of macroscopic damages we see in tendinopathy. The most abundant cells in that tendon are the tenocytes, right? So not only is the collagen getting eaten away, but the tenocytes are getting affected. So I won't go into all the details, but there's a host of literature on how the inflammatory cells are and the chemokines and cytokines are affecting the actual tenocytes, right? So the tenocytes are responsible for pumping out the type 1 collagen and making this kind of a normal tendon. But the inflammatory cells affect that, and they cause the tenocytes to start pumping out other things that are not as desirable, such as type 3 collagen, which is less biomechanically advantageous than type 1 collagen. There's other issues I mentioned in my work. I showed that picture of the synovium, right? So again, this is kind of a global pattern. It's not just happening in the tendon, for instance, in the shoulder, but it can happen in stromal cells that are nearby. So if, for instance, if you have in the shoulder, if your synovium is all inflamed, right, because it's reacting to tendinopathy for a variety of different reasons, you get increased inflammatory cells there. The synovium gets activated, it starts pumping out chemokines, cytokines, et cetera, and that has an effect directly on the tenocytes themselves. There's a bunch of things that have been looked at as kind of markers for this. I mentioned it in the bottom bullet point below, but the point is that once this process gets started, it's hard to stop. All right, so we throw corticosteroids at it, we throw anti-inflammatories at it, we throw rest, rehabilitation, things like that. But it's hard to stop this inflammatory process because it's happening in multiple different locations and has multiple different causes. Just another paper showing that the stroma and the surrounding tissues can become a problem. IL-1 as well as other interleukins are a major factor in this. And this is just showing that these cell surface markers in particular are getting activated and leading to activation of the whole inflammatory pathways, which we're going to talk about at the end of the talk as means to target them. The last thing I mentioned is these mast cells, right? So the last kind of coup de grace on top of everything we've talked about are these resident mast cells that are normally just hanging out and being pretty quiescent there. But when you start this whole process, these mast cells get activated. There are some things such as M2 macrophages, which can cause calming of the process. The M2 macrophage is kind of anti-inflammatory. But once these mast cells get up, it's just yet another step on this ladder of inflammation that goes on. So again, multifaceted, multifactorial reasons to have inflammation within the tendon. The last thing you're going to ask is, okay, so we have tendon breakdown and tendon issues and structural changes in the collagen, right? So this collagen, type 1 collagen, for instance, is getting eaten away. Well, that's a problem, right? And the reason it's a problem is because of these DAMPs and alarmins. So the DAMPs basically are proteins that are cleaved off and eaten away by, for instance, macrophages, things like that. And they're circulating in the environment, all right? So think of a macrophage going to a type 1 collagen triple helix and eating it and cleaving it in half. The problem with that when it gets cleaved in half is that the body no longer recognizes it as native. So now the body in some form or another says, hey, wait a minute, this isn't quite what should be here. I'm going to recognize it, for instance, as an invading pathogen. And I'm going to activate my immune cell, the innate immune system, to try and attack this and get rid of it. Well, that's a problem, right? Now that we've got activation of the immune system, not just the local inflammatory environment, but now, again, we're bringing in things from the circulation, back to what we talked about before. And it takes time to clear that. But in that clearance process, right, that's an inflammatory event. And because of that, yet another reason to have inflammation in there. So just briefly, I mentioned the innate immune system, right? The innate immune system is this kind of this shotgun approach to remove foreign debris. It recruits immune cells to the site of damage, and in tendinopathy, this is unfortunately what's happening, and we know this through multiple studies. It's kind of that short burst, for instance, if you get a cut on your skin, right, and it turns red within the first hour or so, that's the innate immune system getting activated and trying to rid that foreign pathogen. Well, the problem with that, right, as I mentioned, is that cleaved collagen, that cleaved type 1 collagen is being recognized as a foreign pathogen in some form or another in the tendon. And that's what's causing or leading to and perpetuating the inflammation and the eventual clinical courses that we see in tendinopathy. So what does it do? The innate immune system, as going back to kind of my first kind of paradigm of the first picture where the blood cells are coming in and macrophages are coming in from the immune system. Well, once that process gets started for real, it brings in all those extra macrophages from the circulatory system, and it continues the process, right? So once that process gets started, it's really hard to stop, particularly if you continue to work out on that tendon and continue to do things. And even with rest and rehabilitation, right, 30–40% of people don't get ultimate resolution of their problem. So this is still going on and still happening. And this is going to be a site of kind of clinical targets that we'll talk about at the end. The other thing is we have activation of complement. Bill Robinson here at Stanford kind of published, it was our rheumatologist, kind of looked at this in particular and was one of the seminal papers on just yet another inflammatory factor on what's going on here. So it's a hard problem to solve because of all these factors. So innate immunity, you can just think of kind of the shotgun approach. It's just this initial blast versus the adaptive immunity with immunoglobulins and things like that, more targeted therapy. And so we're not talking about adaptive, we're talking just about innate immunity. So the innate immune system, this is a picture of a toll-like receptor, which is a generic transmembrane receptor on the right here. these toll-like receptors are activated by this whole immune process, right? And NF-kappa B, which is a major transcription factor, goes and once these receptors are activated, they get NF-kappa B going to the nucleus and serving as a transcription factor for a whole host of additional cytokines and chemokines. So that's what the innate immune system is doing, and that's how this process continues to get perpetuated by, for instance, this is one of the main receptors that happens. And these receptors, unfortunately, not only respond to pathogens and invading pathogens, things like that, but they also respond to those damps that we talked about, or that cleaved in half collagen fibril that I mentioned that happens from mechanical damage or from inflammation. And so when these toll-like receptors see these cleaved collagen, they get activated and the innate immune system continues on. So anyway, you can see there's just a cycle that continues to happen. You get inflammation, you get collagen damage, you get activation of the toll-like receptors, you get more chemokines and cytokines, you get more invading macrophages, and so that just goes round and round and round, and that's the process that's hard to stop. There is some crosstalk between the compartments, of course, and there are some therapies that are really just in vivo at the moment, looking to stimulate M2 macrophages, for instance, trying to stop the inflammatory process. It's really tough to do. Sometimes M2 macrophages, even in the lab, aren't enough to do it when we're continuing to test these things. But it's one area of target that we're looking for. And then resolution often, in addition to these M2 macrophages, just takes additional anti-inflammatory things. So in some studies, they're actually dumping COX-2 inhibitors or COX-1 and 2 inhibitors into a petri dish to see if they can stop this process. And sometimes even that is enough. Even that is not enough at lower doses. So a whole host of reasons. I'm going to move on to the next section here. That's hopefully the boring stuff is out of the way, but I just want you to recognize that there's a whole host of issues in there that are going on. And so it's hard to target just one and get clinical resolution because of all these other factors that are in play. So what are the cytokines involved? This is it. And the reason I like this figure a lot is because it shows the receptors on the cell surface there, and a lot of these receptors are targeted by some current drugs that we have available. A lot of it is crossover from the rheumatology research and subsequent drug development that we'll talk about at the end. But it's really a mechanistic process, right? This is a receptor ligand type problem that we're looking to solve, and it's a tough process, but we'll talk about it. So IL-1 being one of them. So IL-1 is, a big pro-inflammatory cytokine, not only in tendinopathy, but in arthritis and everything else also. The problem is IL-1 will downregulate collagen production. So in addition to causing an inflammatory reaction, it can actually downregulate collagen production by the tenocyte. So this is a major issue in tendinopathy. IL-33 is instance. We don't talk about IL-33 a lot, at least in clinical orthopedics, but there is a prelim small molecule that looks to target this and looks to affect this mechanism and this pathway here. IL-33 was shown to be a kind of a major inflammatory component that looked to downregulate collagen 1 and upregulate collagen 3, which is what we don't want in tendinopathy. We want more collagen 1 and less collagen 3 or no collagen 3. And so IL-33 is a target, and it works through the NF-kappa B pathway. IL-6 we talk about all the time. Major issue in arthritis, well, also a major issue in tendinopathy. I would say IL-6 probably the number one inflammatory marker for tendinopathy if we're going to look at kind of the standard things. And there's no question that IL-6 is exuberantly present in tendinopathy. It can upregulate collagen production, but unfortunately it does upregulate collagen production of things that we don't really like a lot, such as collagen 3, collagen 5, other higher number collagens, which are not collagen 1 and lead to problems. TNF-alpha, a big one, of course, we talk about in a lot of other diseases. We have really good TNF-alpha inhibitors in medicine and rheumatology that are used all the time, of course. People have tried injecting TNF-alpha inhibitors into tendons, and it just really hasn't produced the clinical effect that we would like. IL-17 is another one, and the reason I mention this, there's a drug on the market, Cosentrix, for rheumatoid arthritis and other inflammatory arthropathies that looks to target IL-17, and there's some decent early clinical data that it can help overall with tendinopathy and enthesopathy in inflammatory arthropathy type of patients. So we talked about the resolution pathways. Other things can be tried. M2 pathways we talked about already. People have even looked at putting aspirin in there. So in a petri dish, aspirin actually has an anti-inflammatory effect in tendinopathy. But when we look at the database literature, there's been no large clinical trials I'm aware of. But when we look at the database literature, it doesn't really parse out, probably because there's too many confounds on whether aspirin actually helps tendinopathy. But aspirin can be anti-inflammatory and downregulate some of the pathways here, CD206 and ALX15. But in general, it's not a big clinic. We don't use it clinically, of course. So this is the kind of the meat of the talk that the clinicians will be kind of most interested in, and kind of what do we do to treat tendinopathy? And kind of half of this you probably heard before, and the other half maybe newer information. So what do we treat? So if someone comes to my clinic with tendinopathy, we're talking about activity modification and also eccentric exercise program, right? So this is still the standard, and still, no matter what it is, tennis elbow, Achilles, patella, shoulder tendinopathy, we still treat it with physical therapy. And for certainly the kind of non-shoulder pathologies, we're looking at eccentric programs. And that really has clear level 1 evidence, and that's still the answer regardless of everything I've said today. The newer techniques, there are some rehabilitation techniques that talk about isometrics or heavy slow resistance training, things like this. These are on the rehabilitation side of the paradigm, and something that we're not going to deal with as orthopedic surgeons quite as much. But there are these aren't new, but newer techniques in addition to eccentric training that the therapist can throw on to tendinopathy patients and be successful. So corticosteroid, right? So we use it all the time for shoulder tendinopathy. We use it sometimes for elbow tendinopathy. We really don't use it, or as I'd say, as a sports medicine kind of specialty, we've moved away in using it from patella and Achilles tendinopathy. But it makes sense, right? It's a really potent anti-inflammatory. So everything I mentioned before, it would make sense to throw a little cortisone in there. The problem is we know cortisone can be damaging not only to tenocytes, but there's good data that it's not really healthy for chondrocytes either. So tenocytes and chondrocytes are kind of both finicky cells, and they go together. And so the short-term effects, for instance, from a tennis elbow injection are actually pretty good. But in the long term, the patient pretty consistently in the literature comes back with the same problem. If they don't go through other treatment modalities, to come back with the same problem. And if you do it repetitively, just like we'd expect anywhere else, it's really not good for the structural integrity of the tendon. But it works, and we still do it. And I think a single corticosteroid injection is still a reasonable thing to do for upper extremity tendinopathy. One thing we have moved away from is perioperative cortisone injections for shoulders. So for instance, if someone's going to be coming up on a rotator cuff repair surgery, we really try and not give them a cortisone injection within the first, within a few months of surgery. There's a bunch of database studies that show it's associated with increased re-tear rates. So just another marker that cortisone is not the greatest thing for the tendon. In sports medicine talks, we have to have a slide on PRP, but there's level 1 evidence really started for PRP in lateral epicondylitis. A lot of the work on Alan Mishra here in Stanford and Menlo Park. Alan published a bunch of early studies on it, good studies, and that still exist, and those are still kind of quoted articles. And I'd say we still offer this. Insurance doesn't cover it, of course, most of the time, but it's still something that can be used for tendinopathy, and a very reasonable thing to do. I'll even, if patients have the means, I'll even say you can skip the corticosteroid, for instance, for tennis elbow, and go straight to PRP. It just depends on their financial situation, but it's a very good, acceptable treatment, of course. Achilles, at least in the football world, we're using it less and less on the Achilles. We've seen that it just hasn't, at least in the higher level athletes, it hasn't worked quite as well as we want it to. It doesn't mean we don't use it. We're just kind of moving away from it and focusing more on other things. In the shoulder, there's pretty little evidence that it works. We get people that ask for PRP in the shoulder all the time. And sure, if they've got a lot of money and they want to do it, that's fine. But I really am honest with them that there's no good evidence for it at all. The white blood cell rich versus white blood cell poor PRP issue as a whole, another topic. I would say in general, if we're looking at tendinopathy and patients have time for rehabilitation, we're looking at white blood cell rich mixtures for tendinopathy versus arthritis, for example, where we don't want to stimulate the inflammation anymore because there's already a lot of other problems in there. And you're looking at white blood cell poor for the arthritis type populations. But for the tendinopathy, the data is pretty good on white blood cell rich. It adds the inflammation for a while. But the PRP proponents will say that some of the cytokines and chemokines in there are anti-inflammatory also for whatever reason. And they do have some data to support that, but we will often give white blood cell rich for tendinopathy for it to be most effective. Oral NSAIDs, of course, can work. We use it all the time. Nothing new there. Shockwave therapy. Shockwave therapy is actually not a bad thing to do. I can't tell you that the evidence is great. Most of the data is in kind of the non-orthopedic literature, PM&R, and also some rehabilitative literature, of course. But it does work, and there's some good data to show that that works. Insurance, again, is more difficult to get it covered. So it's not a mainstream use, but I do recommend it. I do talk about it with people as a viable option. The high volume saline injections were used a lot in Achilles tendinopathy. You actually kind of stick a needle in there and inject saline in there. Not commonly done in the US a lot, but it is an option. I just mentioned it here because there is literature on it. Nitroglycerin. So this came up, now it's been about 10 years for this. So this is a nitroglycerin patch that is given for angina patients. And so a guy in Australia, George Morell, came up with the idea saying, okay, if we can maybe stimulate some blood flow to the area, which is what nitroglycerin does. Of course, it's a vasodilator. Maybe that can help for some reason. I'm not sure I haven't asked him what his original thinking was on it, but he looked at it for lateral epicondylitis at first, as well as patellar and Achilles tendinopathy, and did find some benefit. There's believers and there's non-believers, but I've given this to a number of athletes as kind of just a trial. The downside is some of them can get headaches, but the dosage is pretty small here, so it's a pretty rare reaction. I'd say it's 50-50 whether it works or not in terms of what they say, but it is yet another option that's out there. It's not used a lot, but it's something we do use when we've kind of hit the end of the road and their surgery is not a good option and they can't go. Sclerotherapy we use less in the United States, so basically just looking at sclerosing little blood vessels in there. It's done mostly under ultrasound guidance. As you can imagine, it's technically challenging. Europe does it a lot more than we do. For whatever historical reasons, just not a major treatment in the US, but it yet is yet another thing. These are more physical therapy-based modalities. So iontophoresis and phonophoresis, basically ionto, just using electrical stim to get dexamethasone, for instance, down through the skin onto a superficial tendon, such as the patella, such as the Achilles, patellar tendon or Achilles. Therapeutic ultrasound, basically just taking an ultrasound probe and getting ultrasound energy of the tendon. There's hyperthermia, there's friction massage, there's even laser therapies. There's laser therapy journals out there that show that shining whatever wavelength of red light on the skin can penetrate the skin and cause beneficial effects to the tendon. I don't use it, but it actually is used in the rehabilitative training rooms and physical therapy clinics as part of the modalities. There's no harm in it. I'm just not sure there's an effect. Autologous tenocyte injection. This came up maybe about 10 years ago as a kind of a pilot study from a group in Australia. They published on AJSM. It hasn't really been followed up, and we don't really do it anymore, but there is some case series showing that, of course, it helps because it's a case series. It's not a randomized controlled trial. And in a number of different pathologies, but again, it's out there. It exists, but we don't use it too much. Tenex. So Tenex is a thing. Bernie Morey came here. I don't know, maybe it's been 5 or 7 years ago when this whole company was starting up, and it's basically under ultrasound guidance using this little probe to kind of ablate the tendon. So instead of surgically removing the damaged tendon, This is a minimally invasive way to kind of do the same thing. Their literature, the company-based literature, suggests it's highly effective. Other non-company-based literatures don't really have such great results. There's really a lack of kind of comparative trials in the literature, as you'd expect. With it takes a lot of money to fund these studies, and the company doesn't want to do it with risk of not finding good results, of course. But their literature does support it, and it's actually it's a valid option. I'd say it's a low-risk valid option. Our ultrasound specialist, Dr. Rose and Fredrickson here, will do it. And it's not wrong. It's certainly, surgery for tendinopathy in general is not the answer, which we'll talk about in a sec. So I'd say it's a nice bridge, and yet another option in the treatment paradigm. Surgery as kind of the last resort, I would say Achilles tendinopathy and patellar tendinopathy and lateral epicondylitis, from a sports medicine's perspective, we still do surgery rarely. That's at the end of the line when the athlete or person comes to us and says, look, I've tried all of this, I've got nothing else, and we have nothing else to offer besides surgery. What the literature would suggest, though, in the trials is that surgery really doesn't help. How much of a placebo effect there is, we never know, but in general, it's really a mixed bag on surgery, and we try very hard to not operate on tendinopathy. Okay, so the translational therapy. So I kind of showed that green cell at the beginning with all the receptors. And I'm just going to go through a few of those receptors and the drugs that bind them to talk about what's out there on the market, basically. So anakinra is an IL-1 receptor antagonist. It was tried, it's probably been 20 years ago or so, that actually got tried for osteoarthritis. And osteoarthritis, again, it actually is also an inflammatory disease. So a lot of the stuff is run through arthritis first and then comes to the tendon world later. It did show some benefit in the lab, but when we try to inject it in the small trials into tendons, it really doesn't have much of an effect. But there is a drug out there that's available, but again, it hasn't really reached potential in the tendinopathy world. So there's both an injectable and there's also a soluble IL-1 receptor, and a couple small trials in the tendon world. Again, it just doesn't work clinically. The IL-33 I mentioned earlier, with that European trial, there's a phase 1 going on now with a company over in Europe looking at that particular one. We'll mention other ones that are further along in the process, but again, looking to target that particular pathway on that slide I showed earlier. Other ones, these are IL-6 monoclonal antibodies. They are rheumatoid arthritis medicines, as I talked about a lot. A lot of these are come from the rheum literature. In general, as I say, these are in really early phase tendon treatments. Again, the small case series have not been promising. And there's a lot of reasons for that. Obviously, we're still figuring out how to get it into the tendon, whether it can be soluble, whether it needs to be injected, whether there can be oral administration. Of course, if you do orals, right, there's a whole host of other problems that these things can cause. So we're really trying to focus on local administration of these drugs for the otherwise healthy tendinopathy patient. Just interesting that that these things, IL-6, were trialed for COVID symptoms back in the day to kind of reduce the whole body inflammation that was seen in COVID. The TNF alpha inhibitors are well known, been on the market for a while. I think a couple of them are coming off patent or have come off patent just recently. Reports of, again, as I mentioned, injection in the Achilles, mostly for inflammatory arthropathy patients. In that patient population, it can work. We just haven't taken the leap to inject it into healthy, otherwise normal patients with tendinopathy. But it certainly remains, a promising thing, and some case series to show that it's done in inflammatory arthropathy patients. AL-17 is Cosentyx. You probably see, or at least a few years ago, there was a large advertising campaign for Cosentyx for the rheumatoid and inflammatory arthropathy patients. And right now, Novartis is doing a phase 3 trial for rotator cuff tendinopathy for this drug. And so they're looking to expand indications for this beyond the inflammatory arthropathy patient, of course. I don't know what the results are there, but we're looking at it. They're looking at it for rotator cuff things. Other pathways that weren't on that green cell slide that I mentioned are the Wnt beta-catenin pathway. There was a company down in San Diego called Sanimed that actually went out of business because their trial here for their small molecule inhibitor in the Wnt beta-catenin pathway didn't work. They got bought up by someone else, but this was yet another pathway they looked. So this is just a paste that they were putting on tendinopathy patients on the skin and hoping for absorption into the tendon. It just didn't really work that well, unfortunately. The JAK inhibitors, see ads for this again. So these are the JAK1 and 2. We haven't moved towards clinical use of these at all, even in small trials. But we're studying in a lab to see if this can blunt the inflammatory effects. So basically, we're just repurposing a lot of these meds.
Somebody was talking. Oh, is this one? Okay, sorry. Sorry,
Mute myself back on my computer, Shay.
So this is just this is a picture from my lab looking at these stem cells. So we're finally, the original paper came out 15 years ago, but it takes effort and time and skill to be able to isolate these things in a lab. Tenocytes, just like chondrocytes, are real finicky cells. And there's not a lot of them in our tendon samples that were taken from our patients. So it takes a while to grow. But there's many different ways to try to affect these. There's viral transfection mechanisms to try and put in certain growth factors to try and affect them. But suffice it to say, yet another area of research to look at other than the receptor ligand pathways we've been talking about. We're looking at trying to modulate these tendon stem cells to kind of keep on the straight and narrow and keep creating tenocytes to pump out that type 1 collagen. MicroRNA is yet another thing. I mentioned it here. It's a focus of the lab that I'm in, and basically microRNA is these little short snippets here of kind of 40 to 50 nucleotide things that kind of bind to the messenger RNA and kind of mostly prevent translation. And so yet another way that we're looking to affect not only the inflammatory cascade, but also tendon stem cell regulation. And the tendon stem cell regulation, not only with microRNA, but with other factors, is really the Wild West right now, right? So the paper that isolated them just came out 10 to 15 years ago. And so there's a whole kind of host of people working to affect these things. And there's a paper that comes out every week showing some new factor, obviously, that affects these tendon stem cells. So it's really all over the place right now, and there's not a good one answer to how to regulate these things. So the unifying theory, right, is there's this inflammation that happens. We get the bad collagen coming up. There's tendon stem cell regulation. This all happens together. So it's it's been presented piecemeal in the talk, of course, but it's all happening at the same time. And I mention it because that's the real challenge of this pathology, just like arthritis, where there's a million things going on that we're trying to affect. So we solve one problem, but then 100 others pop up, or we solve the IL-1 problem, but we upregulate IL-6, or vice versa, right? So that's the problem we're dealing with here, and it's just not straightforward. And certainly there's no cure currently on the horizon, but lots of people are of course working on it. So just a brief effort, where I spend a lot of my time, so I have to put in a few slides. But anyway, my current lab efforts, we're really looking to develop a 3D model of tendinopathy. So the problem historically with tendon disease or studying tendon disease is we do it in a petri dish, right? With a cell monolayer culture, just these cells laying in the petri dish. That's not really how tendinopathy works. So tendinopathy is, obviously three-dimensional, but it's also three-dimensional with mechanical forces on it. So what we developed with the help of Wente Chang, who's in the lab with me, we developed this three-dimensional construct, which we can see the tenocytes on. They can attach to this construct, and then this little paperclip thing down at the bottom, we put a little mini MTS machine on it, and we can stretch it. And we can obviously vary the amount of stretch we're doing. So we're stretching those cells to try and create not only the three-dimensional crosstalk that they have and three-dimensional structure, but we're also putting mechanical stress on it. And at least I think there's a couple other people working on it in the US and Europe, but I think that's the best way to study tendons. It just happens to be really difficult. We've actually spent the past 6 to 9 months perfecting just the model. And just a few months ago, we think we've got it when we added about 30 to 40% stretch to the whole system. We started down at kind of 5 to 10%. It just wasn't enough, so we had to upregulate it. But what we do see is that actually it works finally after 7 or 8 months, I guess now, that we finally kind of dialed it in. So we know that the cells are there. They're attaching to the microribbon. They're living cells. They're not dying. They're persisting in the environment. And then when we put up, for instance, 30 to 40% stretch on that little paperclip picture I showed you, we finally see the effect of tendinopathy. So if you look at the chart on the left, we're looking at collagen 3 over collagen 1. So collagen 3 is bad. That's the numerator there. So the higher bars represent more collagen 3. And we're finally able to recreate that collagen switch that we see in native tendons, where we get this upregulation of collagen 3 and the neutral or downregulation of collagen 1. We see upregulation of collagen 6, and there's other slides that I won't bore you with, but in general, we finally have gotten that taken care of, and I'll be publishing on it, of course, but this is just the first step, right? This is the base model. And so we're going to use this model to test all those other factors, that we showed. So we're going to be dumping medication into this model to see how it affects the tendon stem cells, the inflammatory regulation. So it's just going to serve as a model for a test bed to see which things work best in terms of treatment. So last slide is, if anyone tells you that tendinopathy is not inflammatory, they just don't know the literature. And it's really clear that this is more than a mechanical stretching effect model as we thought about it 20 plus years ago. This is a clear inflammatory component. Certainly mechanical forces induce the problem, but then inflammation, innate immune system, things like that perpetuate it. All the established treatments are still valid that we do in clinic, of course, but we're really looking to move beyond that, the translational model, to really piggyback on a lot of our rheumatology colleagues and their research to try and find ways to treat the inflammation at its core and possibly affect the stem cells, et cetera, that are in there.